let's talk about something very uncomfortable. Perianal abscess and fistula. Both of these are two closely related anorectal conditions that every clinician and surgeon must understand. A perianal abscess is an acute infection, while a fistula in ano is often a chronic consequence of that infection. Today, we're going to cover relevant anorectal anatomy, pathophysiology, types and classification, risk factors, treatment options, and success rates. So let's review the anatomy. The story starts with the anal glands. These glands drain into the anal crypts at the dentate line and pass through the internal sphincter. If one of these glands become obstructed, bacteria proliferate, leading to an infection and an abscess formation. From there, the infection can spread into different anatomic spaces. And hence we have this picture here, which shows a perianal abscess, an ischiorectal abscess, an intersphincteric abscess, and a supralevator abscess. Understanding this anatomy is critical for predicting abscess location and fistula trajectory. So how does this happen? Most cases follow the cryptoglandular hypothesis, in which an obstruction in an anal gland occurs, followed by bacterial overgrowth, abscess formation, and persistent tract formation between the anal canal and the skin, which is actually the fistula. Importantly, 30 to 50% of patients with an abscess will eventually develop a fistula even after proper drainage.
Almost 98% of people watching this aren't subscribed. If you're a medical student or resident who wants to think more clearly, prepare more efficiently, and perform better under pressure, this channel is built for you. Click the like and subscribe button and let's keep on going.
As we talked about the different types of abscess, let's actually go back to the classification. The perianal is the most superficial one and is the most common. The ischiorectal, which is deeper, is more extensive. Then we have the intersphincteric in between the internal and external sphincters. And supralevator is rare, but is also very complex. Symptoms include severe anal pain, swelling, fever, and difficulty sitting or defecating. Now we're going to talk about anal fistulas, which can happen up to 30 to 50% from people who develop perianal abscesses. As I mentioned, fistulas are a connection between the anal canal and the skin, secondary to the abscess formation that extend to both directions forming this tract. Fistulas are classified using the Parkes classification, and there are 4 types. The first one is going to be an intersphincteric fistula. The tract goes in between the internal and external sphincter. Next one is a transsphincteric. The tract goes through both internal and external sphincters. The suprasphincteric goes above it and then through it. And then the extrasphincteric. They are also categorized as simple, which is low tract, minimal sphincter involvement, and complex, which is high tract, recurrent, multiple tracts, presence of Crohn's disease or anterior fistulas in women because it may affect the vagina. This distinction guides management and sphincter preservation. So what are the risk factors? Prior perianal abscess, Crohn's disease, diabetes, immunosuppression, smoking, and obesity. Crohn's-related fistulas behave very differently and often require multidisciplinary management. For abscess treatment, ASCRS is clear. Prompt incision and drainage is mandatory. Antibiotics alone are not sufficient. We use antibiotics with adjunct for surgery in people who are immunocompromised, diabetics, and those with extensive cellulitis. Delaying drainage increases risk of sepsis and fistula formation. If somebody has an anal fistula, this basically presents with persistent drainage and recurrent abscess formation. Now we're going to go to treatment options and success rates. The first one, fistulotomy. That means cutting the tract open. it's the gold standard for simple and low fistulas. The healing rate, 90 to 95%, with risk of incontinence if excessive sphincters are divided. And that's why it's very important to utilize imaging such as the MRI to delineate how much sphincter involvement there is, because if you're going to cut the tract, you want to preserve the external sphincters, which maintains your continence. Cutting that one may actually cause a disastrous complication leading to incontinence of the patient. The second option, seton placement. This is used for complex or high fistulas. A draining seton controls sepsis. How does this work? When you place a seton, which is something to allow drainage of a tract, which could either be a vessel loop or a suture, this allows the tract to continue to empty by keeping it open while having that foreign body in there. What's a cutting seton? A cutting seton is used selectively due to incontinence risk. What you do is, it's not based on the material, it's actually the suture itself or the vessel loop that you tighten progressively. As it tightens, it sequentially cuts through pressure necrosis of the sphincters. However, this still has a risk of causing incontinence with the damage, even though it's sequential. So the thought process is sequential cutting. And when you tighten it sequentially, it allows the seton to cut through slowly, allowing the further portions to heal while preserving some of it as it goes through. Third, advancement flaps. And these are sphincter sparing. The success rate is 60 to 80%. So this involves creating a flap of mucosa, which will then cover the fistulous tract. Fourth one is the lift procedure, which is ligation of intersphincteric fistula tract. Its success rate is 60 to 80%. It has low incontinence risk. And it's basically cutting the tract in the middle. And the last one is fibrin glue or plug. It's minimally invasive. You could either inject the fibrin glue into the tract or suture a porcine-derived plug to cover the fistula tract. And this is technically a biologic and allow it to heal. However, this has low success rates at 30 to 50% and is often adjunctive, but it has no risk or very, very minimal of incontinence. One important thing to keep in mind is ASCRS emphasizes balancing healing with continence preservation. So what are the key recommendations? Drain abscess promptly. Do not aggressively search for fistula during acute infection. Tailor fistula treatment to anatomy and patient risks. And prioritize sphincter-sparing approaches for complex disease. Perianal abscess and fistula are common, but management errors can lead to chronic disease and incontinence. Understanding anatomy, classification, and evidence-based treatment is the key to optimal outcomes. If this helped, please click the like and subscribe and check out the channel for more high-yield education. Check out the videos up there and I'll see you guys next time.